My name is Peter Schwartz. For 20 years I've been the chairman of the Department of Cardiology at the University of Pavia in Italy, and since 2013 I am the director of the Center of Cardiac Arrhythmias of Genetic Origin at the Istituto Auxologico in Milan. My training was primarily in basic experimental research together with clinical research, and the reason I'm talking to you today is that for almost 50 years I've been involved in the management, treatment and therapy of patients affected by the long QT syndrome. This slide shows the main features of the congenital long QT syndrome. It is a genetically transmitted disease. Its prevalence is close to 1 in 2,000. It usually manifests in young age, anytime after birth, so it does include some cases of sudden infant death syndrome and beyond. A prolongation of the QT interval is its main feature, but we are aware now that there are cases, as we will see, that have the disease with a normal QT interval. Frequent syncope or cardiac arrest, especially during emotional or physical stress, are a cardinal aspect of the disease. Very importantly, there is a high mortality among symptomatic and untreated patients. At the same time, there is a high efficacy of available therapies. These last 2 points indicate clearly that it's totally unacceptable nowadays the existence of symptomatic and untreated patients. In the case of the long QT syndrome, its prevalence is not estimated. It's actually based on data, and this data come from a very large prospective electrocardiographic study in newborns, almost 45,000 of them. They had in first ECG between the 3rd and 4th week of life. A second ECG was performed whenever the QTc exceeded 440 milliseconds, and molecular screening was performed in those with prolonged QT interval. These data indicate that the prevalence of long QT syndrome is likely to be close to 1 in 2,000. The main ECG features of the long QT syndrome include a QT interval prolongation, T-wave alternance, notched or biphasic T-wave, and a lower than normal heart rate at rest and during exercise. It has to be kept in mind that the diagnosis does not rest solely on the actual measurement of the QT interval, but also on an assessment of the configuration of the T-wave. For this reason, I'll show you a few examples. This tracing comes from the first publication on the long QT syndrome made by Professor Anton Jervel in Oslo. And you see how bizarre are the T-waves. Look at V3, for example. This slide comes from my very first patient and was recorded in 1971 in January. You see a major prolongation of the QT interval in A, and in B you can observe the phenomenon of T-wave alternance, which I then recognized as typical for this disease, and it's actually rather pathognomonic. These are other examples of T-wave alternance in one of our patients. This is an important feature because it's pretty unique for this disease, and it is also a profibrillatory phenomenon. As you see indeed in this slide, the onset of torsade point follows a period of T-wave alternance. So whenever you see T-wave alternance, you have to keep in mind that you are dealing with someone with increased propensity to life-threatening arrhythmias. T-wave notches are also important. You see the arrows pointing to these little humps after the top or the peak of the T-wave. They are very typical indeed, particularly of the variant called long QT syndrome type 2. And this is another example of T-wave notches. Please keep in mind that for the diagnosis Pattern recognition is important. You shouldn't simply measure the QT interval. You should, as I said many years ago, look at it. When looking for the diagnosis, sometimes the resting ECG looks normal. A 12-lead Holter is extremely important because it can show you, like in this case, major changes occurring at night time. So whenever you're dealing with a suspicion of long QT syndrome, perform a 12-lead Holter. Also looking at the exercise test is useful, particularly examining the changes that take place in the first few minutes after cessation of exercise. In the last 25 years, I and my colleagues have proposed a series of diagnostic criteria, and they are helpful particularly for those who are not very familiar with the disease. I, for example, don't use it, but it can be very useful for someone who has seldom seen such a patient. It's a score with points, and the issue here is that if you are dealing with someone who has 3.5 or more points, the probability of long QT syndrome is high. You see on this slide the number of features that provide points for the diagnosis. Genetics have radically changed our approach to the long QT syndrome, from its understanding, management, and therapy. Everything started in 1995 with 2 publications, followed by another one in January 1996, which identified the main 3 genes responsible for this disease. We know that there are additional at least 13 genes that can cause long QT syndrome, but 3 are the fundamental ones. They are KCNQ1, HERG, SCNN5A. They encode respectively for 2 potassium currents, IKS and IKR, and 1 sodium current. The terminology has been affected by this identification because now we don't talk anymore of long QT syndrome in general, but we talk about LQT1 when the mutations affect the IKS current. We talk of LQT2 when mutations affect the IKR current, and of LQT3 when they affect the sodium current. Few words about these 3 currents. IKR is rapidly activated. That is why it has an R. It is blocked by many cardiovascular and non-cardiovascular drugs. IKR blocking drugs are a leading cause of drug-induced long QT syndrome and can trigger torsade de pointe. It is essential that patients with any type of long QT syndrome never take drugs containing an IKR blocker. IKS, the other potassium current, is enhanced by catecholamines and becomes the predominant potassium current in conditions of high sympathetic activity. Mutation on IKS impair QT shortening when heart rate increases, and thus you have to understand and realize immediately that a mutation on IKS would become extremely dangerous and important whenever heart rate increases suddenly. The sodium current is important because the mutations produce a late inward sodium current which lengthens the plateau phase of the action potential and thereby the QT interval. The realization that there was an excess inward sodium current led our group already in 1995, few months after the discovery of the gene, to try something, to try to interfere with this mechanism. This led, as you see here, for this publication in December of 1995, where with my group we were able to show for the first time the possibility for gene-specific therapies. An older drug, mexiletine, a well-known sodium channel blocker, was able, in our very minute population of LQT3 patients, we had only 6 in those days, to obtain a major shortening in the QT interval. I wish to conclude this part of the presentation by showing you how understanding the mechanism of action and the timing of activity of the various ionic currents influences also the measurement of the QT interval. What you see here is a classic action potential configuration. In the next slide,
this rather ugly action potential allows me to show you in green the inward depolarizing currents and in red the repolarizing currents. When there is a deficit for IKS and IKR leading respectively to LQT1 and LQT2, there is a change in the shape of the descending limb of the T wave and the QT is prolonged. And you realize by its first X where is the end of repolarization. A lot of people use the tangent method by which you would underestimate the actual duration of the QT interval. The tangent method should not be used when studying the long QT syndrome patients.
I have covered several aspects and I couldn't enter into many details. These 3 articles may be helpful for those of you who want to understand more about some of the specific points that I've been discussing. Thank you.